So let's close this out, right? I don't know if we have enough time for this topic, but I think it's going to be interesting, right? So myths, hallucination, and the truth, right?
I'll tell my patients all the time when they say, "What do you think I should do as far as the vaccine?" And I say, "You should make an informed decision." And they say, "Well, what should I do? What do you want me to do?" And I let them know what my biases are. I have been in the healthcare system since 2002, and I've seen a lot of things, including deaths and, just what we call morbidity from vaccine preventable illnesses. As it relates to COVID-19 and the COVID-19 vaccine, in terms of like hallucinations and things that just aren't the truth, when we talk about nanoparticles, we're just talking about a little droplet of fat that has that mRNA in it. And so the hallucination is a microchip is going to be put in us. We all walk around every single day with our microchips in our hands. It's our cell phones, okay?
Yes,
Nobody
ma'am.
needs to put
Yes,
anything
ma'am.
in us in order to track what we're doing. These cell phones know what you think, want, and need before you even process it in your mind, because they know you so well. So your microchip is your phone. No one needs to put one in you. The vaccine is what we call messenger RNA. So it is literally a transcript of the spike protein of the virus. So the hallucination is that the vaccine can change your DNA. It cannot. The messenger RNA doesn't even go inside of the nucleus. That's where all of your DNA is stored inside of your cells. So the hallucination is that this that this vaccine is going to affect our DNA. Someone came up with some, I'm going to just say a hypothesis, right? Somebody not working in the clinical trials for these vaccines made sort of an educated guess and said, oh, there could be a possibility of infertility because a protein on the viral spike protein looks similar to a placental protein. And people took this and ran. And now every woman of childbearing age and every woman who's waiting to become a grandma wants to know, is this vaccine going to cause infertility? No, that is a hallucination. That's not something that was proven. And, the side effects of the vaccine, having an achy or painful arm, having a headache, having fevers or chills, having 2 to 3 days of fatigue, or having muscle aches or joint pains for 2 or 3 days, those symptoms are very predictable. That's a truth, right? And we know that there's a small proportion of people, like 1 in a million people, who can experience an allergic reaction that is severe called anaphylaxis from the vaccine. And none of those people have died from that reaction. They have all been treated and recovered. When I'm talking about the vaccine and I'm just informing my patients, I let them know that you are comparing side effects of the vaccine, not to nothing at all, but to what is going to happen if I get COVID-19 infection. Am I going to be one of those people who got a mild infection? Am I going to be one of those people who become critically ill, or I'm going to be one of those folks who die?
Before it's
I
open,
wanted to I wanted to ask a couple questions, and hopefully you can help me out. So I asked the several doctors that I normally cut, and I asked them. They said something about me having a positive blood type, and that was kind of like one of the things that was kind of like universal as far as not getting, or low to no.
No.
It's not.
So, no. So the thing with the blood type was, I think it was like a 40% decrease in the severity of COVID-19 infection. And that data came out early on. And the thing is we're learning as we go. So no blood type is protective from COVID-19 infection. No skin color, no amount of melanin. There's no nothing. Okay. COVID is like the bully on the block. Everybody could get it. Okay.
Right.
So it doesn't matter what your blood type is. You have to consider other things as well. What's your weight? Do you have high blood pressure? Do you have diabetes or pre-diabetes? Those are the top 3 risk factors for people to have, severe adverse outcomes with COVID-19.
Dr. Noble, why don't you chime in?
Yeah.
Is health a predictor, like, or I guess how healthy you are, is that a predictor of you getting COVID? And then the severity of what will happen to you if you do get COVID, right? Depending on how healthy you are. I think that's question number one. Question number two is follow the money, right? So are health systems remunerated for COVID to, label this death as a COVID because there's some type of incentive payout, or are they, extracting more funds than they need to, because this is a pandemic?
And when you look at the categories for 1A, 1B, 1C individuals, I think there are individuals that should get the vaccine. For individuals that are high risk, working in environments, healthcare workers, things of that nature, yes, I agree that they should get it. As far as some of the points as far as the healthiness, Dr. Alexea said it perfectly. It's the bully on the block. So regardless of how healthy you are, or it's hard for us to predict how someone's going to respond to COVID-19. As far as the diagnosis of COVID-19, what we have found is that yes, it can cause heart attacks, and especially with young people, because COVID-19 causes blockages in very small arteries. And so when you have these blockages, whether it's in the toes or elsewhere in the arteries of the heart, yes, it can cause a heart attack. And then when someone is diagnosed, or they do a postmortem, or they take a lab and they find that that person has COVID-19, there's a list of things that they could probably say this person died from: cardiopulmonary arrest, maybe their heart stopped, their lung stopped. But with COVID-19, they sit there and kind of check the box. The question is, does that lead to more money or resources? Yes and no. And the reason why it's yes and no is because when someone is COVID-19, that means the acuity or how severe the care was is higher than someone that didn't have COVID-19. And so when we talk about acuity and how sick someone is, that can lead to more resources or dollars going to that. And there's a higher charge for taking care of patients that require ICU stays, ventilators, and all these other things. So there seems to be some sort of corollary between a COVID-19 diagnosis and cost, just because those with COVID-19 end up eating up a lot more resources and need more resources to take care of that. And so that's where it came to be, this whole debate and discrepancy of, are we diagnosing individuals with COVID-19 for the money versus individuals that have COVID-19 require more resources. And if we don't diagnose this person with COVID-19 and we don't get the resources necessary in our institution, our acuity doesn't reflect on paper what it actually should be. So it's a very sort of confounding sort of issue, exactly similar to what we're seeing with older patients getting vaccinated and then dying. From the standpoint that the average age of death is 75, so any day after 75 is a blessing. So when you start vaccinating people that are 80 and above, it's just natural that those individuals are going to die. But is it related to the vaccine? Probably not. It's probably not related to the vaccine. It's probably just the fact that the person was 80. But because we're mixing data and all these confounding variables, it's very hard to kind of tease out what's the causality of the ultimate in death.